Hello students. In today's session we are going to discuss about pharmacotherapy of urinary tract infections. To understand any pharmacotherapy, we should know the disease pathophysiology in detail, which organisms are responsible for development of that disease, especially UTI for this case, what is the goal of therapy, clinical presentation, and how it is going to be treated with drug, without drug, pharmacological aspects, and non pharmacological therapy. Let's start with the introduction of urinary tract infection. Infections of the urinary tract represent a wide variety including urethritis, which means infection and inflammation of the urethra, cystitis, meaning infection and inflammation of the urinary bladder, prostatitis, which means infection and inflammation of the prostate gland, and pyelonephritis, which means infection of the kidneys. Around 60% of female develop an episode of UTI during their lifetime. And among these females, about one-fourth of them will be having recurrence of the UTI within next to 1 year. The frequency of occurrence of urinary tract infection is low into males, but as the age advances up above 65 years, the incidence is almost equivalent to females. According to one survey, urinary tract infection accounts for 8 million patients visits annually, which means it is very common condition which you will be encountering in your day-to-day practice. That is why it is very important to understand the disease and its treatment. Now we come to the types of urinary tract infection. Urinary tract infection can be divided into two types based on their anatomical site of involvement. First is upper UTI, which means involvement of the kidney, that is pyelonephritis, and other variety is lower UTI, which includes urethra, bladder and prostate. So infections included are urethritis, cystitis and prostatitis. Based on the structural and functional abnormalities associated with the urinary tract infection, it is divided into two categories, uncomplicated UTI and complicated UTI. Uncomplicated urinary tract infection means there is no structural or functional abnormality into the urinary tract, while complicated UTI means structural or functional abnormality is there into the urinary tract, which is responsible for the development of infection. And what is recurrent UTI? When any patient suffers from more than or equal to 3 episodes of urinary tract infection within a year, and if it is a female, then non-pregnant female should be considered, then this incidence is considered as recurrent urinary tract infection. This is the diagrammatic presentation of the types of UTI. Upper urinary tract infection, which includes kidney and ureter, while lower urinary tract infection include bladder and urethra. If patient is male, then prostate gland is located here. Then in males, lower UTI include urethritis, prostatitis and cystitis, while upper urinary tract infection means pyelonephritis. Now we come to the causative organisms. Which organism cause urinary tract infection? Most frequently they are gram-negative bacilli. 95% of the cases of urinary tract infection are caused by gram-negative bacilli, while only 5% of cases are caused by gram-positive cocci. Responsible organisms are E. coli, Protease, Pseudomonas and Klebsiella. Enterococci, streptococci and staphylococci can also cause urinary tract infection. If it is uncomplicated UTI, unless specified, it is considered to be caused by E. coli, because 80 to 90% of cases of urinary tract infection are caused by E. coli only. As Saprophyticus, Klebsiella pneumoniae, Protease, Pseudomonas aeruginosa and Enterococcus are other organisms which may lead to uncomplicated UTI. complicated UTI, 50% cases are caused by E. coli, followed by protease, Klebsiella pneumoniae, Enterobacter, Pseudomonas, Staphylococci and Enterococci. But by and large, if you see here, either it is complicated UTI or uncomplicated UTI. Most common organism causing UTI is E. coli. Now we understand the pathophysiology of urinary tract and its infections. Factors which determine the development of infection into the human involve certain parameter. First of all is size of inoculum and virulence of organism, which means the amount of bacteria which has entered into the urinary tract and their virulence will decide the severity of the infection. There are certain host defense mechanisms located into the urinary tract. First is washout during micturition. During the process of micturition, with the flow of urine, most of the organisms which are there into the urinary tract, they tend to wash out during this process of urination, which gives a host a natural defense mechanism. Normal urine pH is around 5 to 5.5, and at this pH there is usually inhibition of bacterial growth. Moreover, urine is having high content of urea and usually hyperosmolar in nature. These two factors will also inhibit the bacterial growth. And it is said that the destruction of the organism is caused by direct antibacterial action of the bladder mucosa also. Urinary bladder mucosa is also having some amount of antibacterial activity which can kill the bacteria which are there into the bladder. Sometimes it is identified that some patient suffers from more than one type of organism simultaneously. Such type of urinary tract infections are called as mixed infection, where UTI is caused by either E. coli or Klebsiella simultaneously, E. coli or protease simultaneously. There are more than one organism responsible for development of UTI. This type of UTI are called as mixed infection. They are little more difficult to treat, and this happens more frequently into the chronic cases of UTI, into the patient those who are suffering from diabetes, those who are having obstructive uropathy, and those with indwelling bladder catheters. Now we see the clinical presentation of UTI patients. Signs and symptoms are described here. If patient is suffering from lower UTI, then symptoms would be dysuria, that is pain while urination, urgency, frequency, nocturia, suprapubic heaviness, and sometimes gross hematuria. While in patient suffers from upper UTI, the symptoms include flank pain, fever, nausea, vomiting, and malaise. When you do the physical examination of the patient, in lower UTI, generally no sign is seen, but into the upper UTI, there is a presence of costovertebral tenderness, which is responsible for the inflammation of the kidney. Certain laboratory tests are required for the diagnosis of UTI, of which most common is urine examination. In urine examination, you will find that there is a presence of bacteria, and bacterial count is more than 10 raised to 5 CFU per ml. If you go for the blood count, WBC count is usually more than 10,000. There is a presence of pyuria, that is presence of WBC into the urine also, that is WBC count more than 10 per mm cube, and either there is a presence of microscopic or gross hematuria into the urine. But most definitive method of diagnosis is the urine culture, where you take a sample of urine, grow it into the culture medium, identify the organism, and then you label that it is a UTI caused by this bacteria. So how we proceed for the diagnosis? We require urine sample. To collect the urine sample, there are two techniques. One is midstream clean catch technique. When patient is asked to collect the urine into the container, patient is advised to allow initial 1 to 2 seconds of urine flow and contain the midstream urine also excluding the last few seconds of the urine flow. That is called as clean catch technique, which is usually devoid of any contamination from the skin or surrounding structures. Or if patient is not willing to do so, you can go for the suprapubic bladder puncture. Usually urine collected from the urinary bladder is considered to be sterile. So even one organism is found into the bladder puncture sample, then that is the confirmed case of urinary tract infection. But most reliable method is urine culture, where you are doing quantitative culture or colony count of the urine. Colony forming units are, if they are more than or equal to 10 raised to 5 per ml, they are designated as significant bacteriuria, which is a diagnostic feature of urinary tract infection. Now we come to the diagnostic criteria for significant bacteriuria. It is identified as more than or equal to 10 raised to 2 colony forming units of coliform per ml or 10 raised to 5 CFU of non-coliforms per ml in a symptomatic female, more than or equal to 10 raised to 3 CFU of bacteria per ml in a symptomatic male, more than or equal to 10 raised to 2 CFU of bacteria per ml in a catheterized patient, and any growth of bacteria on suprapubic bladder puncture in a symptomatic patient is the diagnosis criteria for significant bacteriuria, and that patient is labeled as a patient of urinary tract infection. Now, how to treat the patient of UTI? For that, we are going to set some of the goals for the therapy. Treatment goals are: first is to cure the infection. We need to cure the current episode of urinary tract infection. Prevention and treatment of recurrence. We should design the therapeutic regimen in such a way that there is no recurrence or relapse after this episode. Identification and treatment of predisposing factor, which is very necessary for UTI, and symptomatic relief is at most important into the patients of UTI, because when patient comes to you into the OPD, he suffers from dysuria, frequency, nocturia, burning pain, and very much discomfort, sometimes fever associated with UTI, and you need to give the symptomatic treatment for these symptoms also, so that patient feels better. Symptomatic relief can be achieved by altering the pH of urine or by giving phenazopyridine, which is a urinary analgesic, which we are going to discuss little later. First, we start with the general principles of the treatment of urinary tract infection. In acute cases, how we should proceed is: an appropriate drug must be started immediately after the urine sample collection. Acute cases means patient has history of onset of urinary tract infection in 3 to 5 days or in previous 1 week. These cases are considered as acute cases, where you collect the urine sample, and as soon as the urine sample is collected, you administered appropriate antibiotic, which you assume as a broad spectrum or covering the most of the organism which you have suspected by your clinical examination. Most common in this case is E. coli, because we know that 90% of cases of UTI are caused by E. coli. So you start with a drug which is effective against E. coli. Another drug may be substituted if necessary when the result of drug sensitivity are available after urine culture examination. But in chronic cases, there is no desperate hurry or there is no immediate requirement of antibiotic, because here you have to investigate the case thoroughly. In chronic cases or recurrent UTI, there is always presence of some anatomical or functional abnormalities, either obstruction into the urethra, obstruction into ureter, presence of urinary stone, or some anatomical abnormality. This needs to be ruled out by different investigation as per the requirement, like USG or CT scan. After you come to a proper diagnosis, then only you start treating the patient, because in chronic cases there is no hurry in prescribing antibiotics. Next principle is that the effective drug must achieve adequate concentration in the tissues as well as into the urine. And as far as possible, bactericidal drug is preferred for the management as compared to bacteriostatic drugs. Drug must be used in adequate dose and for the adequate period so that complete cure is achieved with complete removal of the bacteria and chances of recurrence are very much reduced. You should try to maintain the pH at optimal level. Adequate alkalinization of urine can be achieved by giving 2 gram, that is almost half teaspoonful of sodium bicarbonate, sodium citrate or potassium citrate, which help in inhibiting the bacterial growth. And most important for the treatment of UTI is that patient should take as much amount of fluid orally as much he can take. Liberal fluid intake is very much encouraged to the patient because flow of urine is one of the mechanisms through which organism can be thrown out of the body. So now we come to the classification of the drugs which are used into the treatment of UTI. Bacteriostatic drugs are sulfonamide, tetracycline and nitrofurantoin. Bactericidal drugs are cotrimoxazole, extended spectrum penicillin, fluoroquinolones, aminoglycosides, cephalosporin. And urinary antiseptics are nitrofurantoin, methionine mandolate and nalidixic acid. So how to choose for a drug for the treatment? First, you have to select an appropriate antimicrobial agent because UTI is 90% of the times caused by bacteria, and for killing of bacteria you need to give appropriate antimicrobial agent. So how to select this antimicrobial agent? It is selected based on certain criteria which include severity of the presenting signs and symptoms, the site of infection, either it is upper UTI or lower UTI, either the patient is uncomplicated, just a simple UTI, or patient is complicated or of recurrent or chronic UTI, antibiotic susceptibility pattern into the local area, and safety of the antimicrobials also. You should look for the ADR profile also. Ability of the agent to achieve appropriate concentration into the urine. Considering this parameter for each antibiotic in mind, you should select appropriate drug for the given patient. Second drug which is used is urinary analgesic. It includes phenazopyridine. If required, one can prescribe that. Fluid hydration is advisable but not the forced diuresis. And there is some role of urinary alkalinizer and acidifier so that pH of the urine can be changed, which help in inhibiting the growth of the bacteria. This is the list of antibiotics which are working based on the acidic or alkaline pH. Drugs which are more active in acidic pH are nitrofurantoin, methenamine, tetracycline, cloxacillin. In alkaline pH, cotrimoxazole, aminoglycoside, cephalosporin and fluoroquinolones. And ampicillin is a drug, their role is not dependent on the pH of the urine. But this classification is considered as arbitrary and you can give any drug to any patient of UTI. So we discussed the role of each drug into the UTI. Previously we have covered these drugs like fluoroquinolones, aminoglycoside, trimethoprim, sulfamethoxazole combination as a separate lecture. So you know these drugs very well. Now we are going to discuss their role into the UTI only in very brief. Trimethoprim sulfamethoxazole combination, it can be used as an empirical drug of choice without having any bacteriological data. It is highly effective against most aerobic enteric bacteria except Pseudomonas. High urinary tract tissue level and urine level is achieved with cotrimoxazole. That is why it can be useful for treatment of UTI as well as for prophylaxis of recurrent infections. Second drug is penicillin, which include ampicillin and amoxicillin clavulanic acid. They are broad spectrum penicillins because broad spectrum penicillin has coverage on gram negative organisms also. But nowadays, increasing resistance with the penicillin has been reported by E. coli. So currently, no one uses penicillin for UTI. Still, it can be used as drug of choice for enterococci, which is sensitive to penicillin. Cephalosporin, they are more effective against Klebsiella and protease. But third generation cephalosporins are preferred because they have wide coverage of gram negative organism. These drugs are more expensive drugs. They are useful in cases of resistant to amoxicillin and cotrimoxazole patients only. Fluoroquinolones, they are currently considered as drug of first choice for most of the UTI because they have greater spectrum of activity including Pseudomonas. They are also valuable in complicated cases, in prostatitis and in resistant cases also. But the only problem is fluoroquinolone cannot be given into the pregnancy or into the children. Next group is aminoglycoside like gentamicin, tobramycin, amikacin. Tobramycin is having better pseudomonal activity. Amikacin is reserved for multi-drug resistance bacteria causing UTI. Next is tetracycline. You know that it is a broad spectrum drug, can be used for any infection, but the problem is resistance develops very rapidly and it has long list of adverse drug reaction which limits its use. It can lead to candida overgrowth as a super infection, but it can be useful for primarily as a anti-chlamydial drug for the treatment of chlamydial UTI. Azithromycin can be used for the single dose therapy for chlamydial infection. Fosfomycin can be used as a single dose therapy for uncomplicated infections. Carbapenem and monopenem, which include imipenem celastin combination, having broad spectrum of activity including gram positive and gram negative and anaerobic bacteria. That is why they are reserved drug for hospital acquired infection. Next is estrionam, which is effective against gram negative bacteria including Pseudomonas. Nosocomial infections, when aminoglycosides are to be avoided and the patient is penicillin sensitive, then you should go for estrionam as very reserved drug, rarely used nowadays. Now we come to nitrofurantoin. It is a bacteriostatic drug. It can be useful for treatment of resistant infection, mixed infection and into the patients of obstructive uropathy. It is effective as both a therapeutic and a prophylactic agent in patients with recurrent UTI only. Because it is a bacteriostatic drug, it is not preferred for acute episode of UTI, but it can be useful for prophylaxis of recurrent infection. Main advantage is that the drug does not develop resistance. No organism develop resistance with nitrofurantoin even after a long course of therapy, which makes the drug very suitable candidate for the treatment of recurrent UTI where you need to continue the therapy for more than 6 months. It achieves high urinary concentration, but it has very poor tissue levels. That is why it is unsuitable for the treatment of renal parenchymal infection. Adverse effects include GI intolerance, neuropathies and pulmonary reactions. Next drug is methenamine mandylate. It is a salt of mandelic acid and methenamine. How it works, mechanism of action is that at acidic pH of urine that is less than 5.5, methenamine is converted into formaldehyde and mandelic acid will help to lower the urinary pH. If patient's urine pH is not less than 5.5, then mandelic acid will decrease the urine pH below the 5.5 so that methenamine can be converted into formaldehyde. And formaldehyde, as you know, that it is a drug it is a substance or solution which can inhibit growth of most of the microorganism. Advantage is that there is lower chances of resistance in chronic suppressive therapy because drug act by virtue of its chemical nature. But it is not effective into the acute and upper urinary tract infection. It cannot be useful for treatment of protease and Pseudomonas infection. Dose given is 1 gram 4 times a day. Larger doses can cause acute inflammation of urinary tract itself because of the formaldehyde is a aldehyde, and aldehyde is a irritant substance which can irritate the urinary tract mucosa, leading to acute inflammation by itself. Next drug is phenazopyridine. It is a azo dye which is excreted into the urine, and it has very much higher local analgesic effect. Indications are after the use of a catheter or after penile surgery. If you give phenazopyridine, it relieves the irritation and discomfort caused by the surgical procedure or by the instruments like catheter, because it is having local analgesic action into the urinary tract only. It does not mean that the drug is analgesic. It cannot be used for pain of other region except urinary tract. Dose is 200 mg 3 times a day for not more than a week. Adverse drug reactions are also very high. Because it is a azo dye, it colors the urine into red or orange color, and it can stain the clothes also, which may be embarrassing for the patients. It can lead to stomach upset, fever, headache, dizziness and confusion. It can lead to skin rashes, shortness of breath, swelling of face, and it may lead to hemolysis in patients with G6PD deficiency. So in such cases, it is absolutely contraindicated. And animal studies have shown that azo dye is one of the carcinogenic substance, and long-term use may produce bladder carcinoma as a side effect. So this drug is rarely used nowadays because patient has come to you with into the OPD with the symptoms of urinary pain and mild fever and burning micturition, and you give a drug by which patient has a risk of development of bladder cancer, then that drug is not acceptable by the patient. So for selecting any drug, you should weigh the benefit against the possible risk before prescribing. Now we come to the actual drug therapy of uncomplicated lower UTI, what to be given. In the prescription of uncomplicated lower urinary tract infection, what is the meaning of uncomplicated lower UTI? Which means patient has infection of either bladder or urethra, and patient does not have any structural or functional abnormality of the urinary tract. It is just simple infection of the urinary tract, which is treated with norfloxacin 400 mg twice a day for 3 days, or you can give cotrimoxazole, one double strength tablet twice a day for 3 days. You can give amoxicillin 500 mg twice a day for 5 days, or nitrofurantoin 100 mg 4 times a day for 7 days, or nitrofurantoin monohydrate 100 mg twice a day for 5 days, or amoxicillin clavulanic acid 500 mg 3 times a day for 5 to 7 days. Here you can see that the font size decreases as the stage of the slide goes down, which means the first written drug or the drug which is written into the bold letter is the drug of choice, and the others are alternative into the same sequence as mentioned below. Phosphomycin 3 gram single dose can be used for the uncomplicated lower UTI, but it is a costly option. Now what is complicated lower UTI? Which means patient has infection of the bladder or urethra along with some structural or functional abnormality of the urinary tract. So here you have to give ciprofloxacin 500 mg twice a day for 7 to 10 days. Why in complicated cases we are giving ciprofloxacin, and in non-complicated cases we are giving norfloxacin? If you remember the class of fluoroquinolone, there is slight difference into the pharmacokinetic of ciprofloxacin and norfloxacin. Norfloxacin has tendency to get concentrated into the luminal structures only. while ciprofloxacin has more tendency to get accumulated into the tissues. So if renal parenchymal tissue is affected, you have to give ciprofloxacin because that is the fluoroquinolone which reaches the tissue level. If you are suspecting infection of the bladder, which is a lumen, or urethra or ureter, which is a luminal structure, then you can go for norfloxacin because it achieves very high concentration into the lumens. Here we are dealing with the complicated cases, which means there is some type of obstruction which requires thorough treatment including tissue clearance. That is why we prefer ciprofloxacin 500 mg twice a day for 5 to 7 days. Or you can give cotrimoxazole 1 double strength tablet to be taken twice a day for 7 to 10 days. Here the duration of treatment also differs. Into the lower UTI, duration of treatment is 3 days only, maximum up to 5 days. 3 to 5 days is the duration of therapy for uncomplicated lower UTI. While in complicated lower UTI, duration of treatment is 7 to 10 days. Drug remains the same, drug and dose remains the same. Here it is ciprofloxacin, into the uncomplicated it was norfloxacin. Rest of the treatment are same. Either you can give levofloxacin 250 mg once a day for 10 days or 750 mg once a day for 5 days. Amoxicillin clavulanic acid 500 mg 3 times a day for 7 to 10 days. Now if we are dealing with upper UTI means ureter or kidney, called as acute pyelonephritis, then drug of choice is ciprofloxacin. Obviously, as discussed earlier, it is the only drug which gets concentrated into the kidney. 500 mg twice a day to be taken for 14 days. For upper UTI, the duration of antimicrobial therapy is for 14 days as compared to 7 days of lower UTI. Amoxicillin clavulanic acid 500 mg 3 times a day for 14 days. Cotrimoxazole 1 double strength tablet twice a day for 14 days. Levofloxacin 250 mg once a day for 7 days or 750 mg once a day for 5 days. What to be given for recurrent lower UTI? Here, because of the recurrent case, you need to give long-term antimicrobial therapy. So, here we are preferring cotrimoxazole as 1 or 2 single strength tablet to be taken once a day for 6 months. So, here duration for the recurrent UTI is 6 months. Levofloxacin 500 mg once a day for 6 months. So, drug and dose remains the same, but the duration only changes. Nitrofurantoin 50 to 100 mg once a day for 6 months. Next entity is prostatitis. So, how to treat prostatitis? It is caused by E. coli, Klebsiella, Protease and Pseudomonas. These are the common organism which is responsible for inflammation of prostate gland. Because the prostate gland is surrounded by a tight prostatic capsule, very few drugs can penetrate this prostatic capsule and actually achieve the sufficient concentration into prostatic gland. That is why we need to select a drug which has tendency to cross this capsule and reach the prostate gland. One such drug is trimethoprim. Trimethoprim is a drug which gets concentrated specifically into the prostate. It can cross the prostatic barrier and reach in sufficient concentration into prostatic tissue. Trimethoprim sulfamethoxazole 1 double strength tablet to be taken twice a day for 4 to 6 weeks. Here the duration of treatment is up to 1 to 1.5 months. Ciprofloxacin 500 mg twice a day for 4 to 6 weeks. Levofloxacin 250 mg once a day for 4 to 6 weeks. So here the duration of treatment is 4 to 6 weeks, which is the different. Acute prostatitis with severe symptoms may require hospitalization and IV therapy initially, followed by you can switch over to oral drug therapy. Chronic prostatitis may require longer treatment for the period of up to 12 weeks or if necessary sometimes you have to go for the surgery of the prostate gland, which would remove the prostate gland and make the patient ineffective, sorry, make the patient very much symptomatically better, because the prostate gland is not there, so infection cannot occur. Now last category is urinary tract infection into the pregnancy. What happens into the pregnancy which makes a female more prone to development of UTI? There are certain physiological changes which happens during the pregnancy. This includes severe dilatation of the renal pelvis and ureter because of the back pressure changes, decreased ureteral peristalsis, same because of the pressure created by the gravid uterus, and there is reduced bladder tone. These three together will cause urinary stasis, and there is reduced defense mechanism against the reflux of bacteria into the kidney, which is there into the normal patients. Increased urine content of amino acids, vitamins and nutrients encourages the bacterial growth. During the pregnancy, female is taking the balanced diet, and nowadays they are prescribed with supplemental vitamins and micronutrients with protein and etc., which will lead to more concentration of amino acid, vitamins and nutrient into the urine also, and this is create a favorable atmosphere for the growth of the bacteria. Increase the incidence of bacteriuria resulting in symptomatic infection is very high into the pregnancy, and that too into the third trimester. So third trimester is the most common time where UTI develops during pregnancy. Asymptomatic bacteriuria occur in 4 to 7% of pregnant patients, and 20 to 40% will develop acute symptomatic pyelonephritis during pregnancy. If it is not treated during pregnancy, it may lead to prematurity, low birth weight and sometimes stillbirth, and pregnant patient may have to lose the baby also because of the infection, its complications, septicemia, and it can be life threatening. That is why it is always necessary to treat UTI during pregnancy. Organisms which can cause UTI during pregnancy are same as those seen into the uncomplicated UTI, with E. coli as the most frequently identified organism. Antimicrobial agent with low adverse drug reaction and no teratogenic potential, those who are safe to the mother and baby, that is selected and administered for 7 days for the treatment of UTI during pregnancy. So pregnancy is the entity where you have to select a drug which is not a teratogenic, which is safe for the mother as well as safe for the developing babies. Such antimicrobial is preferred. Safer antimicrobial agents are amoxicillin, amoxicillin clavulanic acid, cephalexin and nitrofurantoin. What is the scenario with other drugs? If you remember our previous lectures of chemotherapy, tetracycline is teratogenic in nature, absolutely contraindicated during pregnancy. Sulfonamide cannot be given into the third trimester of pregnancy because of the sulfa drug they produce is kernicterus and hyperbilirubinemia, and it can be dangerous for the developing baby. Fluoroquinolone can inhibit the cartilage and bone growth of the newborn. That is why it is contraindicated during pregnancy, lactation and newborn babies. So we prefer amoxicillin or ampicillin or cephalosporin for this phase. A follow-up urine culture 1 to 2 weeks after completing the therapy, and then every monthly till gestation is complete is recommended for all the pregnant females having UTI. So treatment of UTI during pregnancy is capsule amoxicillin 500 mg is to be taken 3 times a day for 7 to 10 days. After that, you go for the urine culture examination every monthly till the baby is delivered. That's all about the urinary tract infection. I hope you have understand the concept of the disease and its treatment. If you have any questions, you can ask here. Thank you.